Hello. Today we will be talking about the autism spectrum disorder. So what is autism and what is the autism spectrum? Under IDEA, autism is defined as a developmental disability significantly affecting verbal and nonverbal communication and social interaction, generally evident before age 3 that adversely affects a child's educational performance. Other characteristics often associated with autism are engagement in repetitive activities and stereotyped movements, resistance to environmental change or change in daily routines, and unusual responses to sensory experiences. Now, that's the definition of autism, while the autism spectrum or autism spectrum disorders are a more broadly defined term that can incorporate different subcategories. These subcategories include autistic disorder, childhood disintegration disorder, pervasive developmental disorder, not otherwise specified, as well as Asperger's syndrome. So these are all generally considered within the autism spectrum disorders, which we will refer to ASD from here on out. So what are the characteristics? Well, according to the Diagnostic and Statistical Manual of Mental Disorders, people with ASD have difficulty communicating and interacting with people, and they have restricted interests and engage in repetitive behaviors. And these symptoms can affect their ability to function in school and work. So when we really think about it, it's broken down into two main categories: a deficit in communication skills with other people and having restricted interests in repetitive behavior. That said, it is a very broad spectrum, so characteristics can vary wildly from person to person. Um, there are a set number of things that you may see. I have some examples here, but they're not limited to these. But if we were thinking in the deficit of communication skills, people with autism spectrum disorders may have difficulty maintaining eye contact, following a conversation, understanding different tones and facial expressions. And in a more extreme regard, you may see some who don't wish to interact with other people at all. When we look on the repetitive behaviors, you may see things like echolalia, which is a repetition of small words or phrases, or maybe even just sounds, limited interests, and or being overly focused on these specific interests, and it can lead to being resistant to changes in routine or schedule. Autism spectrum disorders, however, can also be reflected in many of the students' strengths, so it should not always be thought of as a weakness. Students with ASD may have the ability to learn information in great detail and retain that information. They could be strong visual or auditory learners, and they can excel in one or multiple subject areas. When we talk about prevalence, according to the CDC, about 1 out of every 54, or 1.9%, of children 8 years old were diagnosed with ASD. We're talking 8 and younger. It is more common in boys than girls, and it affects communities across racial and ethnic lines, so there's not a racial or ethnic component to ASD. However, when we talk about risk factors and causes, while there isn't an exact known cause of autism or autism spectrum disorders, some known risk factors say that having a sibling with ASD would increase your risk, having older parents, and having a very low birth rate. These can be predictive, and it suggests a genetic nature, but we're not totally sure. Now we're going to watch a video that helps us talk about the diagnosis process.
In 2013, the 5th edition of the Diagnostic and Statistical Manual of Mental Disorders was published. Many diagnoses and conditions were affected by these changes, and in particular, the categorization and criteria for autism was revised. In DSM-4, pervasive developmental disorder was the broad umbrella term, which included autistic disorder. Now in DSM-5, these PDD diagnoses were combined into a single category called autism spectrum disorder. In addition, 3 clinical domains were collapsed into 2 domains so that deficits in social interaction and social communication are one, and the second is restricted repetitive patterns of behavior, interests, and activities. The goals of these changes are to improve the diagnostic process and making a diagnosis for physicians, psychologists, psychiatrists. As with many psychiatric conditions, it is important to screen early for autism and to make a prompt diagnosis. Pediatricians are recommended to screen for developmental issues and early signs of autism at 18 and 24 months of age. Parents are asked to complete questionnaires about their child's behavior. The goal of this early screening and diagnosis is to lead to early intervention. At Western Psychiatric Institute and Clinic of UPMC, the Center for Autism and Developmental Disorders has a specialized and comprehensive approach to early intervention in autism. Some treatment strategies used in early intervention include early intensive behavioral intervention, utilizing techniques such as applied behavior analysis and discrete trial training, as well as parent management training and parent-child interaction therapy. The goals of these are to work with the parent and child to improve their behavior, the child's behavior. As the child gets older, there's a focus on social skills training to help improve social interactions, interpersonal relationships, and to help in working with peers. The implementation of DSM-5 provides a unique opportunity for psychiatrists to reevaluate their diagnostic and clinical approaches to working with children with autism. The goal of the DSM-5 change was to simplify the diagnosis and to add criteria and categories to help in working with children and adults with autism.
And I think an interesting point that this video discusses is that while we talk about the diagnostic process happening in a fairly early age and the early interventions happening around that time as well, people with ASD do not grow out of having autism. So these interventions really remain a lifelong process to help improve outcomes later on in life as well. So when we talk about some of the screening tools, there are different screeners that that can be used. They interact with parents and ask them questions about how they interact with their child. There might be some role-playing scenarios that sort of analyze the child's interactions. Because as mentioned before, there's not a specific genetic marker that leads to this diagnosis. It's much more of an observational process. So when we think about accommodations and modifications, there's a lot of things that can happen in the classroom to help our students with ASD. It can be some of these, and it is not limited to these, but you can provide those daily schedules that provide routine and prepare the student when those routines are going to be broken up. You can offer more frequent breaks. You can, if there are issues with sensory overload as far as sound or light, you can find another environment that might be more accessible to work in. Providing visual cues and reminders, and using alternative media sources as well. When we think about more extensive modifications, you might see a reduction in work. You might think of alternative forms of communication for students that are completely nonverbal, using picture exchange systems. And you could have adult services provided, like a paraprofessional, that would give more support to the student in the classroom. There are lots of interventions that are promising with children and students with ASD. Among the most common are social skills interventions that really aim to work on these deficits that kids may have in communication. So an article that I read was about a specific intervention called the Superheroes Social Skills Intervention. And it really wants to take the best evidence-based practices that we already have and deliver them in a easy to deliver package. So this package included using peers to model the skills, using video modeling, and then having the students with ASD self-monitor the target skills, and then continue to assess using social stories and social narratives. Now, in this particular intervention, there were two students, Nicole and Brian, that they worked with. Both diagnosed with ASD. However, they are different. Obviously, their own individuals, but they had similarities in that they had very infrequent interactions with their peers, and when they did interact, it wasn't always appropriate. So they were both chosen for the intervention because of those reasons. The article does make mention that Brian made further gains than Nicole during this particular intervention, but both students demonstrated an increase in time spent engaged with peers. So what they did was they had a baseline and they would observe in these 10-minute free play situations the percentage of engaged time with other peers, and then measuring that after the intervention, it showed a real gain for those students. So those are some of the interventions that could possibly be used for students with ASD. Thank you very much.